Okay, hi, I'm Lauren Pommert. I am a leukemia oncologist at Cincinnati Children's, and today I will be talking about oncologic emergencies. As you've seen on everybody else's slides, this is the way we're going to go through it today. And these are the topics we're going to cover: tumor lysis syndrome, hyperleukocytosis, superior mediastinal syndrome, increased intracranial pressure, spinal cord compression, and febrile neutropenia. So first, tumor lysis syndrome is a metabolic abnormality that happens from the rapid release of intracellular contents from malignant cells into the bloodstream, and that leads to multiple electrolyte derangements, specifically elevated uric acid, high potassium, high phosphate, and low calcium. And these things can then lead to renal insufficiency, cardiac arrhythmias, seizures, and occasionally death. This is the most common emergency that we see in patients with hematologic malignancies. So as far as the pathophysiology goes, the degradation of the DNA to purines and phosphates causes release of intracellular potassium, phosphate, and nucleic acids into the bloodstream, as I mentioned. And xanthine oxidase converts these purine analogs into hypoxanthine, xanthine, and uric acid. And then the uric acid and the elevated calcium phosphate can crystallize in the kidneys, leading to nephropathy, poor electrolyte or fluid excretion, and electrolyte derangements, and ultimately volume overload. The hyperphosphatemia causes secondary hypocalcemia, and cytokine release can cause hypotension and inflammation and lead to more renal injury. The clinical symptoms of tumor lysis syndrome include nausea, vomiting, lethargy, edema, fluid overload, as I said, cardiac dysrhythmias, seizures, muscle cramps, syncope, altered mental status, and then ultimately you can have death related to these complications. As far as the electrolyte derangements go, there's no kind of widely accepted abnormality, but we consider kind of some of these cutoffs for elevation or a 25% increase from the patient's baseline, though often their baselines are not known when they come into the hospital, and so their labs are already elevated. But as things progress, you can kind of use the 25% increase as treatment goes on. Some things that will cause you to have an increased risk of tumor lysis include a high white count over 50,000, or another high tumor burden like a large mediastinal mass or significant hepatosplenomegaly or lymphadenopathy, especially if you have large intra-abdominal adenopathy such as Burkitt lymphoma. If you have a high tumor proliferation rate, which is often reflected by an elevated LDH. If you come in with already existing kidney injury or dehydration, then this can be exacerbated further. If your kidneys are involved in the oncologic process, just hyperuricemia in general, and then if you have any kind of respiratory insufficiency, that can compromise this as well. In general, these are just some risk cutoff stratifications that show, if you have ALL and you can tolerate a higher white count as compared to AML. We'll talk a little bit about that in a second. So as far as management goes, it's generally symptomatic support. In general, we use aggressive IV hydration, usually 2 to 4 times maintenance rate, without any additives such as any phos or calcium or potassium in the IV fluids, because you don't want to exacerbate any of that further. The goal is to maintain intravascular volume and maintain renal perfusion, and also maintain a high urine output in order to excrete some of these electrolytes. We can, increase urine output by using diuretics if it's suboptimal. However, this should not be used in patients who have hypovolemia or any kind of obstructive uropathy going into it. Urine alkalization used to be a common practice in tumor lysis syndrome. That is no longer the case. This can lead to metabolic alkalosis and worsen obstructive uropathies in the setting of hyperuricemia. So this is no longer used. And then in general, in addition to increasing hydration and maintaining good fluid status, the treatment is supportive for all of the electrolyte abnormalities. For hyperuricemia, we use allopurinol to prevent formation of new uric acid, and resburicase, which is the recombinant urate oxidase enzyme, which rapidly breaks down existing uric acid. Hyperphosphatemia, we can treat with phosphate binders. Hyperkalemia, we use potassium binders, diuretics, glucose, insulin, albuterol, things like that to change the distribution of the potassium. And then hypercalcemia is really only treated if it's symptomatic, because giving calcium into the blood can then cause worsening precipitation with the elevated phosphate, and then ultimately worsen kidney injury. Patients, sometimes despite all the symptomatic care, need dialysis for a period of time, and indications for that would be renal insufficiency, oliguria, if there's volume overload that's leading to respiratory compromise, acidosis, and persistent electrolyte derangements that don't respond to the management that we've discussed. And then in general, you want to follow urine output and fluid status, and generally monitor tumor lysis labs at different intervals depending on how severe it is. This is just a table to kind of go through. You don't need to memorize any of this for boards, but kind of suggested therapies or different medications that you can use in order to treat patients. One thing I should point out that I haven't yet is that for hyperuricemia treatment, rasburicase can be given to patients and works very effectively, but patients should be screened for any kind of family history of G6PD deficiency, which can lead to hemolysis, which you don't need to complicate the picture with that. And then again, the hypocalcemia should be treated only if symptomatic. And if that's the case, hopefully at some point these patients are put into the ICU for closer monitoring and help with this, with nephrology and other services as well. So moving on, next we'll talk about hyperleukocytosis. Hyperleukocytosis is technically defined as a peripheral white blood cell count greater than 100,000. This can lead to multiple different complications, most of which are related to leukostasis or the accumulation of the blasts within the vasculature, which results in increased blood viscosity, and then microvascular obstruction, and then tissue hypoxia. The interactions between the blasts and the endothelial cells then cause secretion of cytokines and adhesion receptors that can further recruit blasts and then lead to further endothelial damage. The clinically significant hyperleukocytosis is related to the size of blasts. So for AML, patients can get into trouble if their counts are greater than 100,000 due to the size of the blasts that are in general much bigger and much stickier in comparison to ALL, which usually tolerates a white count of above 400,000 or really into the 600,000 to 800,000 range before patients get significantly symptomatic. Hyperleukocytosis is associated with specific subtypes of leukemias, specifically infant leukemias and KMT2A rearrangements, AML subtypes, FAB subtypes M1, M4, M5, patients who are in blast phase with CML, patients with T-cell ALL or APL, and patients with pH positive or pH-like ALL all have higher rates of hyperleukocytosis. There are higher rates of early morbidity and mortality in this setting, and that is related to complications of leukostasis, which are intraparenchymal brain hemorrhage, pulmonary leukostasis syndrome, which shows infiltrates on the chest X-ray, tachypnea, and hypoxia. And also patients with high white counts, as I mentioned before, are at risk for severe tumor lysis syndrome and also for DIC. The higher white counts are associated with poor outcomes. So clinical features of hyperleukocytosis and really of leukostasis can range from being completely asymptomatic to having respiratory distress or infiltrates on your chest X-ray. Neurologically, you can have altered mental status, headaches, dizziness, visual field changes. This is often, compromised or complicated by the fact that patients also oftentimes have severe anemia, which can also lead to many of these same symptoms. You can have signs of heart failure or myocardial ischemia, and then also you can have vascular damage, priapism, dactylitis, ischemia, bowel infarctions, and thromboses. So the management for hyperleukocytosis, again, is hyperhydration as the first line, just trying to flush everything out as much as possible, and then also prompt cytoreduction. And that can be done in a number of ways. First, chemotherapy, whether it be steroids or hydroxyurea as a first line, or starting induction therapy right away. And then in the setting of significantly high white count and that would lead to complications with starting induction therapy right away, then leukapheresis or an exchange transfusion is the preferred treatment for that. In addition, management of tumor lysis and DIC, and then trying to maintain a platelet count above 50,000 is also preferred in this setting, especially if patients are getting leukapheresed. Next, we'll talk about superior mediastinal syndrome and superior vena cava syndrome. So superior vena cava syndrome is compression of the mediastinal vessels and or the vessels of the heart leading into the heart. And superior mediastinal syndrome is compression of the vessels in addition to tracheal compression. So this is most commonly seen in oncologic diagnoses that have mediastinal masses. So we typically think of T-cell, Hodgkin and non-Hodgkin lymphoma. Germ cell tumors can also have mediastinal masses, sarcomas, and also neuroblastomas. So symptoms of mediastinal mass would be shortness of breath, cough, stridor, respiratory distress, any kind of orthopnea or dyspnea, chest pain, syncope, changes in voice, hoarseness, wheezing, difficulty swallowing, any kind of effusion, be it pleural or pericardial, facial edema, venous distension, any kind of facial discoloration, and then swelling of the neck and upper extremities. These symptoms are often worsened in the supine position as the mass compresses those structures further. So as far as diagnosis and management, patients should have a chest x-ray performed in the setting of a new diagnosis to look for mediastinal mass, any kind of mediastinal deviation or tracheal narrowing, pleural effusions. Echocardiograms should assess for cardiac function and the severity of the cardiopulmonary compression, and also look for pericardial effusions and cardiac tamponade. Patients will need IV access, obviously, for treatment of this, and that is often needs to be done in the lower extremities due to compression of the upper vessels. Patients often need respiratory support, need to be sitting in a position of comfort, given oxygen, racemic epi, or Heliox. Pericardial and pleural effusions need to be drained as clinically indicated, and sometimes often for diagnostic purposes. If there's no effusion to be drained for diagnoses, then a biopsy of the mass is often needed if there's not some other indication like peripheral blast or something like that. And then in the setting of needing emergent treatment due to respiratory compromise or cardiac compromise, patients can receive glucocorticoids, any kind of empiric chemotherapy, or sometimes emergent radiation. Patients often also need to be anticoagulated if there's significant vascular compression due to the risk of thrombosis, and especially for those patients with leukemia who will ultimately be receiving pegospherogenase as well. In general, the biggest thing to remember about mediastinal masses is to avoid anesthesia, sedation, anxiolytics, and intubation when possible. So the reason that we prefer to do this is because that sedation and anesthesia reduce the respiratory smooth muscle tone and then cause a loss of negative pressure on the trachea with inspiration. So then you have airway collapse and obstruction with that. And unfortunately, that obstruction is beyond where an ET tube can reach. And therefore, if this happens to a patient, there's really no easy way to then ventilate them at this point. So if this can be avoided preemptively, that is obviously better. Same thing with anxiolytics and sedation. They can decrease the respiratory drive and dilate peripheral vessels, which then lead to decreased venous return, which is often already an issue in this setting. And risk factors for those patients who need to receive anesthesia are a tumor that's greater than 45% of thoracic diameter, patients who have less than 50% of predicted tracheal diameter on a CT, or those that have less than 50% of predicted peak expiratory flow on PFTs. Those patients are at specifically high risk of anesthesia complications. Next, we'll talk about increased intracranial pressure. And this can occur also for a number of reasons. It's often a mass lesion that's blocking the flow of CSF at the level of the third or fourth ventricle, or compresses the cerebellum and the brainstem and forcing it through the foramen magnum. This can happen in brain tumors, in blocked shunts, in the setting of leukemic chloromas, in CNS lymphoma, or in infections. Patients with malignant diagnoses can also have pseudotumor cerebri, which increases the intracranial pressure, and that can be treated with retinoic acid and glucocorticoids or therapeutic TAPs, Diamox, things like that. In general, symptoms of intracranial pressure are just irritability, poor feeding in small children, vomiting, headaches, visual disturbances, altered mental status, motor and speech impairments, and sometimes seizures. Increased intracranial pressure and masses can ultimately lead to brainstem compression and herniation and death in some situations. And red flags that you're going down that pathway are Cushing's triad, Cheyne-Stokes respirations, and respiratory arrest. The management of increased intracranial pressure is to get some imaging, depending on the status of the patient, whether that be a CT, which can be done quickly, or an MRI to get a better understanding of what's going on. From a surgical standpoint, steroids are the mainstay of treatment as far as this goes. There's no agreed upon dosing recommendation, though this is someplace that you can start. The thought here is that it decreases some vascular permeability and helps to lower the pressure in that regard. Hyperosmolar therapy, such as mannitol or hypertonic saline, can also be used to shift fluid out of the brain using an osmotic gradient. Sedation can be used in this setting to lower the ICP, and also endotracheal intubation or hyperventilation to cause transient vasoconstriction and decrease of the cerebral blood flow to decrease the intracranial pressure. Ultimately, removal of the mass or ventriculostomy, drain placement or shunt placement is the ultimate treatment, really fixing whatever is causing the issue. Spinal cord compression is next. Can also happen in the setting of solid tumors or liquid tumors. The signs of this would be back pain, any kind of radicular pain or pain in the feet, weakness, sensory abnormalities, any kind of paresthesias, and urinary and stool incontinence or retention, or just difficulty with stool or urination. This obviously is an oncologic emergency that requires quick attention and treatment in order to minimize long-term neurologic dysfunction. And as I mentioned before, this can happen in sarcomas, neuroblastomas, germ cell tumors, medulloblastoma, ATRT, lymphoma. It can be a leukemic chloroma. This can also happen as a hematoma after an LP in the setting of hematologic malignancies. This can happen, up front at diagnosis or later as a result of metastatic disease. So, you always have to be on high alert for this in the setting of these symptoms, regardless of the time and treatment. And STATS MRI of the spine is the imaging modality of choice, though, due to the coordination that takes and sedation, sometimes some things like that, sometimes it's not always feasible. So CT can also be used in an emergency situation, but just doesn't give always great images about the extent of compression. Again, with spinal cord compression, time is function, and the treatment first and foremost is to start dexamethasone immediately. Dosing for this is controversial, as I said, for increased intracranial pressure as well. Surgical decompression is the ultimate treatment for this, but we can also use radiation or chemotherapy to try to shrink it if it's a mass or tumor leukemia pushing on the spinal cord. In general, about greater than 50% of children regain function in the setting of spinal cord impingement, which is very different from adults who have far inferior outcomes. Lastly, today we will cover febrile neutropenia. So fever in an oncologic patient is typically defined as 2 low-grade fevers within a 24-hour period, or a temperature of 38.4 degrees Celsius once. Neutropenia has many different, cutoffs, but in general, we think of those patients with an ANC less than 500 at highest risk of infectious complications. And in general, when these patients are being evaluated in the ER or seen in clinic for this diagnosis, it's important to know their underlying malignancy, what their current disease status is, if they're in remission or not, what their last chemotherapy treatment is, so that you know which specific infections they may be at higher risk for, or complications such as mucositis, what their current medications are, and if they have any prior history of serious bloodstream infections or invasive infections. In general, in examining these patients, it's important to do a thorough physical exam, looking at their general appearance, their heart rate, their vital signs, blood pressure, lung exam, abdominal exam, skin exam to look to see if they have any rashes or anything that could point to an etiology, and then also kind of assessing their cardiac function and cap refill, things like that, to kind of assess where they are in the process and if they're septic. Patients should have blood cultures drawn from all lumens of their central lines to evaluate for infection. Peripheral blood cultures are controversial, not necessarily mandatory, or not necessarily done, I guess, in the pediatric population in those who have ports, but they can increase the detection of bacteremia. And then chest x-rays are also helpful if there's any respiratory symptoms, to see if there's any pulmonary etiology. So as far as treatment goes, these patients need broad spectrum antibiotics, specifically those that cover Pseudomonas is the preferred starting medication. So cefepime is the typically used. Of course, we would like any cultures that are being done to be drawn prior to initiation of antibiotics, but based on clinical status or whatever's going on with the patient, sometimes that doesn't always pan out. In general, adding a second gram-negative agent or vancomycin is reasonable in patients who have a history of a resistant organism or who are at specific risk of other complications like mucositis or strep viridans bacteremia, based on what they received as far as chemotherapy treatment before. These patients often need some kind of fluid resuscitation, whether it be with IV fluids or with red blood cells. And sometimes in the setting of shock, they also need vasoactive support and ICU admission. And the medications used for this will vary depending on if it's warm shock or cold shock, what their blood pressure is, and what the preferred inotrope is in your institution. So moving forward, once these patients are admitted, they need close monitoring of their cardiorespiratory function and need frequent reassessments and physical exams to ensure that the treatment that you're giving them is working and that they are clinically stable and not deteriorating further, as that's the main risk in these patients, as you all know, that they can tank kind of quickly and become very ill. And before it's too late, trying to intervene with fluids and preventing that from happening is preferred. So one of the questions that frequently comes up, or that I'm sure you're used to teaching the residents, is, when do you discontinue treatment in febrile neutropenia? So different institutions all do this differently. So but the general theme is the same. Patients don't need to be on multiple antibiotics if there's no source and they are clinically stable. So you can step down your antibiotic management if they're on multiple drugs after 48 or 72 hours of negative cultures. In general, patients who are low risk, which would be defined by their malignancy and the chemotherapy medications that they received, some can have antibiotics stopped completely if they're afebrile and clinically well appearing. And then you can or some institutions do step down in antibiotics where they transition them to oral for those patients who are low risk and have ability to have close monitoring or follow-up. But in general, the take-home message for discontinuation of treatment in the setting of febrile neutropenia is that patients should be afebrile for 24 to 48 hours. They should have signs of hematologic recovery, which we usually use ANC recovery to define this, or a rising ANC over a number of days, and then no pathogen isolated from their blood cultures or whatever cultures were done for 48 hours in those patients who are high risk. Occasionally, patients who are admitted for febrile neutropenia go on to have persistent fevers despite antibiotic management. And in those patients, we should always have a low threshold to consider more invasive infections of other organisms such as yeasts and molds, and the need to expand antimicrobial coverage in those patients whose fevers don't respond to antibiotic therapy. Specific ways to look for fungal infection, as I mentioned, good skin exams are really important, but blood fungal evaluations can be done and cultures as well, ENT exams of the sinuses or CTs of the sinuses, and then also CTs of chest, abdomen, pelvis to look for infections in the lung or solid organs, which is also important. Treatment escalation for this can be done with micafungin, voriconazole, or any of the conazoles, and AmBisome as well in the setting of serious infections or suspicion for resistant organisms. All right, so that concludes our slides today about oncologic emergencies. We'll go on to our question session. And if you guys have any other questions related to the course, please feel free to email me, which you can find on the first slide. And good luck to everybody on the boards.